Wonderful. Well, we are definitely in the home stretch of an amazing few days. My name is Danielle Kenyon, and I'm a program director for CRCAIH, and have the privilege of working in the administrative division and overseeing the pilot grants program. I'm so excited when these folks get to present on their work and we get to see the findings of these amazing projects. So first I'll give a little overview of the pilot grants program. So what we set out to do was fund cutting-edge transdisciplinary projects. So people were coming together with diverse teams to address the significant health disparities for American Indians in North Dakota, South Dakota, and Minnesota. And we wanted our projects to embrace a social determinants of health theme leading to the improvement of American Indian health. And we were looking for these pilot projects, these one-year projects, to have strong potential for future funding and looking at sustainability of the project, looking at the community collaborations going on in the project, and future opportunities for funding in the future. So the process, this is back when we first started it, would be the RFA would be released in the fall. We would have a letter of intent and application due, and we kept giving folks longer and longer and longer to put their applications together. That was one of the early feedbacks, is we need more time to write. And I worked with great folks in our Sanford grants office here to develop the RFA. They helped do the triage and organize all of that for us. And something unique for our program is that we had an external review panel from folks across the U.S. and Canada from a variety of disciplines and expertise in minority health and research. And we had an external review process and review call. So after getting that group together and scoring on a variety of things similar to NIH, we made the funding decisions within a couple of weeks, and then in the spring requested just in time and let people know. Then those projects were reviewed again at NIH for approval before the funding began. So that's how that journey goes before the project even starts that you get to hear about today. So within the 4 years that we were able to run the program, we received 61 applications, and you can see there in the colors where the applications came from. The majority of the applications came from applicants in South Dakota, and we had a good number from Minnesota and North Dakota as well. And then we also did open it up for eligibility for investigators outside of the region, as long as they were working with community populations within the tri-state region. And you can see who the pilot grants were awarded to, as two of these projects are represented, that we have majority of PIs, again, from South Dakota, with a good representation from all of our states. And what we're really proud of is we had almost half American Indian PIs or co-PIs. And what we saw over time was that we had a lot of great partnerships, that these projects became more tribal and tribal academic partnerships, that these two projects well represented. Great. So as I move into introductions, short introductions, as we have a small time for our panel, Sara Dakota has worked in tribal health for 40 years. She was awarded a Bachelor of Arts in Human Services and the Management from the University of Minnesota-Morris. So wealth of information. She knows, I can't believe how much you can recall dates and things over the past. So we really respect Sara and her work over the years. Bonny Specker is currently Director and Chair of the E.A. Martin Program in Human Nutrition at South Dakota State University. She received her PhD in epidemiology at the University of Cincinnati, and another one of those wonderful, fantastic researchers who does great partnerships in the region. I really admire her work. Mendenhall is a behavioral medicine specialist and associate professor at the University of Minnesota in the Department of Family Social Science. My undergrad alma mater, very proud of that connection. He is also an adjunct professor in the Department of Family Medicine and Community Health and associate director at the University of Minnesota's Citizen Professional Center. And last but not least, Kathy Denman-Wilke is from the Saginaw Chippewa tribe and currently serves as the director of the Department of Indian Work in St. Paul, Minnesota. She holds a Master of Education from, again, yay, University of Minnesota. So please join me in welcoming. We're going to hold questions until the end, and Sara and Bonny will present first.
Good morning, everyone. So we have one of the pilot grants, and our study was the Pregnancy Health Survey for parents of newborns on the Lake Travis Reservation. We our great collaborators and partners were South Dakota State University, and Bonny and her team, and then the team at Sisseton Wahpeton implemented the project. I want to recognize Dr. Sherry Johnson, who is a member of our local Sisseton Wahpeton team. You want to wave your hand, Sherry? They're the ones, they're in the room. So we've talked a lot about health disparities at this conference. The health disparity that we're looking at is infant mortality. The purpose of our study was to find out why some babies are born healthier than others, and also to develop and conduct a pregnancy-related survey for fathers, which hadn't been done before. That was an innovative piece of our project. The information that we wanted to collect was Sisseton Wahpeton specific information to improve services for our families. We had 3 aims to our study. The first was to conduct a survey for mothers using PRAMs. How many of you have heard of PRAMs? It's an instrument developed by the Centers for Disease Control and Prevention. It stands for Pregnancy Risk Assessment Measurement System. And it's been used since 1987 in just about every state in the nation and several cities. It was the Great Plains Tribal Chairman's Health Board implemented it in 2007, and it was implemented here in South Dakota in 2014. The Great Plains Tribal Chairman's Health Board has a grant to implement PRAMs on several reservations this year. The thing that was innovative about our project and new is that we wanted to develop and administer a PRAMS-like survey for fathers. And we also were interested in obtaining Sisseton Wahpeton specific data about toxic stress in childhood, and to investigate whether ACEs scores. How many of you are familiar with the Adverse Childhood Experience Study? So we wanted to see whether there were associations between ACEs scores and parental behavior and outcomes of pregnancy. You can see our 2 booklets. We had separate surveys for moms and for dads. So outcomes. We had 149 births in our sample. That was a 9-month period. Our response rate was 62. We were trying to survey all 149. We were successful in obtaining 62% for mothers and 51% for fathers. Of the mothers and fathers, 62 mother and father pairs completed the survey. And again, this was the first time ever that fathers were invited to complete a pregnancy survey of this nature. So we did get some ideas for improving services. There's a lot of data that resulted from this, so these are just, of course, some bare highlights from it. One is to be able to expand behavioral health services. We already used the data from our study, from our pregnancy health survey, to show the relationship between depression and ACEs scores, to support an application that we submitted to SAMHSA the 1st of March for an Indigenous launch grant. And that an Indigenous launch is to improve mental health in children ages 8 and younger. And of course, how do you improve that? You improve by interacting with the parents and addressing their addressing their depression. We have numerous ways that we could improve on community education, and I'm just going to mention 2 of them here. One of them has to do with folic acid. So we found that 23% of the mothers that we surveyed were using a multivitamin with folic acid during preconception. So there's room for improvement there. In addition, 1 in 3 of those mothers knew why taking folic acid was important. Others didn't have any idea. It might have been covered during prenatal education, or they might have learned about it in school, but they didn't remember it and they weren't applying it themselves. Secondly, with regard to community education, is safe sleep. We found in our survey that the Back to Sleep campaign was very well received in our community, and it worked, but 28% of our respondents said that the baby never or rarely slept in the same bed. So we have room for improvement on that with community education. With regard to surveying the dads, we learned a lot of things. And one is that there's an opportunity to serve dads during prenatal clinic, because 32%, about 1 in 3, attended prenatal appointments. And of those, more than half were attending at least half of the time. So a lot of dads are attending. And the reasons why they don't attend prenatal clinic is usually because they can't get off from work or they don't have child care. So if we could address those 2 issues, we could get more dads to come to prenatal clinic and participate in the community education and possibly receive some clinical services as well. Another opportunity to serve dads is that 47% of the dads that completed the survey said that they were very anxious about the delivery. We feel that we had a great response from fathers. Dads were present for their baby's birth 88% of the time. Most were supportive of their baby mother's decision to breastfeed. And when moms were supportive, the mothers were more likely to breastfeed. Over 90% then did breastfeed. Most of the dads attended well baby checkups as well. We learned that SWO parents are making many positive choices. Chris Rhodes in her presentation this morning talked about smoking. We found out that 48% of the moms, when they find out that they're pregnant, they quit. 91% of the mothers and 97% of the fathers are saying that no one is allowed to smoke inside of their home where they have the newborn. 88% of moms and dads agree that the baby is never in the same room or vehicle where somebody is smoking. 1 in 4 mothers did not use any alcohol at all before conception, and 84% didn't drink during the last 3 months. 74% of the mothers breastfed, and 1 in 3 were still breastfeeding when we surveyed them 2 or more months after the birth. With regard to how ACEs affect parental behavior during pregnancy, we found that there is a correlation between ACE scores. It's correlated with alcohol use in mothers, illicit drug use in both mothers and fathers, and depression in both mothers and fathers. Potential for further inquiry is, as the ResWriter team mentioned this morning, we'd like to focus on strengths rather than risks. That's why we called our survey the Pregnancy Health Survey instead of Risk Survey. And we'd like to change the frame of reference to refer to strengths rather than risks. We'd like a survey instrument that would assess resilience and protective factors for parents. And it would be important to follow up and with this anxiety in fathers about the delivery and do some qualitative interviews to try to understand what that is, and if there are some interventions that we could do if they're coming in for prenatal appointments to try to alleviate that anxiety. Thank you.
Hey guys, we just figured this out. Okay, my name is Ty Mendenhall, University of Minnesota, and I'm just going to do a quick introduction and hand it back to Kathy real quick before I pick up on results. This initiative, just as a quick background and history, started with a project purposely called the Feds, and there's a lot of history in terms of why the project was called the FEDS. It stands for Family Education Diabetes Series. This was about 1,000 years ago when I was in graduate school, late 90s. A lot of our teenagers and even a couple of the undergrads this year have pointed out that that was like when they were getting or born. I think it circles back to yesterday's discussion about sustainability, though, which has been exciting because this partnership, and now as I'm faculty at the university and I went away and then came back, the FEDS as we know it, which is the foundation from which this organization or this project has evolved, has lived and died with and without funding and always come back. We've run it on a shoelace. We've had some good times. We've had some thin times. We've had a lot of robust data collection. We've had some little bit of data collection because that's all that we can do, but the project has always been there. And I think that that speaks to, I think, one of the biggest things that we're proud of is that, you know, when you look at the literature, anybody in academia can't do anything until they do that. Community-based projects usually fizzle and die when the grant runs out. And this project, although we have the grant, thank you, it's awesome that we have the grant, I think when the grant or as the grants come and go that these projects are going to continue. One of the things, though, that happened in our own evolution with the CBPR methods is that the FEDS, as the initial project, was engaging primarily women, and we were losing or not effectively engaging as many men in comparison, and alongside that with our youth. And so as the project continued in its own evolution, we started to partner with other organizations and community partners to do that better and to integrate and connect the dots in ways that we hadn't before. That's primarily what we're going to do and what we're going to talk about here today. The arrow.
There. Okay. Hi. As one of the elders said and reminded Chris, and Chris reminded me, I just want to introduce myself. Anuni Kwe, Indishnakaz, Makwa Dude, thank you, Miigwech. As Ty was saying, one of the things that we found was that FEDS was not bringing in men, and they weren't bringing in youth as much, or youth were just coming for child care while their mothers attended or their grandmothers attended our diabetes series. And so we met as a St. Paul community to talk about how we could increase this effort. And one of the things about St. Paul is it's about half the size of Minneapolis, and you can tell that because the Indian education program in Minneapolis has about 1,600 students, and in St. Paul they have about 900 students, so about half the size. And so St. Paul is about half the size of Minneapolis in regards to the Indian population. We created a purposeful partnership between pretty much all the organizations in St. Paul, except for Jules Fairbanks, which is a treatment center, around this collaborative. And we meet about 4 times a year, but many of the other partners are not here, so I just want to take a few minutes to tell you a little bit about the partners. The Department of Indian Work has been around since the 50s, and it was created out of the relocation program, in a sense. When Indians started to come into the cities, their they were left with many promises not being met, and they were in dire needs. And so the Department of Indian Work was created to meet a lot of those emergency needs. Since that time, we've become, our mission is to create an indigenous space to revitalize culture, wellness, and education. And besides the diabetes program, we also have a youth enrichment cultural program and literacy program, and then we also have a culturally specific food shelf. And so those are the services that we offer. American Indian Family Center is a social service agency that was created in the 70s, which focuses on family and youth program employment, education programs, mental and chemical health support, and they service about 1,000 annually. Ande Young offers an emergency youth shelter, transitional housing, life skills training, legal advocacy, and mental health services. And then St. Paul Public Schools was created with the Indian Education Act in the early 70s, I think it was 1974. And they offer academic help, social service support, academic post-secondary support, and chemical prevention support. So we have a lot of support for our families in St. Paul, and we tend to work together as a collaborative even before this initiative, but this initiative has made us come even closer. So one of the other reasons we collaborated, besides bringing more men and youth into the program, was we really wanted to create a consistent message around health in our community. And I think we have started to do that. We also wanted to create some larger events in which all of our families could attend. And you'll hear about some of those from Ty later in his presentation. But both of those things are very exciting. And you'll see that even though this isn't in our results, some of the results, because of this collaboration, we can see. I'm a Facebook user, and I'm pretty much connected to a lot of people in St. Paul. And so I can tell you right now, I've never seen this, but in the last 4 or 5 years, I'm starting to see people every day say, who's up for a walk today? Who wants to meet me at the Y? Posting indigenous food pictures. Look at what I learned at cooking class. We offer cooking classes in our department. So I really see, and that would be another research project, but I would really love to see how we are changing in a community around that message through social media. So anyways, I just got the sign, and I really need to get to the project and the results.
Okay, so just really quickly, did that say 3 minutes? Woo, here we go. As we were doing our initial data runs with the feds, again, most of our samples were female, or was very heavily female. And so using CBPR methods, we engaged with men and leaders in the community and tackled the question, how do we effectively engage American Indian men in these types of initiatives? And in the long story short, it was outside of the supportive forums or educational sequences that the feds was doing, and more in the community, engaged in canoe building and camping and wild ricing, as you can see here, building or repairing sweat lodges, drumming, dancing, certainly while at the same time having health information and education be part of those sequences. Alongside that, with youth, integrating the, I keep hearing people say it, DEETs and DETs, diabetes education in tribal schools curriculum, alongside information campaigns, health messengers, and activities oriented around the reclaiming of native diet, native activity, native games, again, alongside anything informational that we could give about diet, about diabetes 101, etc. And as we've gone through there, and these are just pictures of them, but as we've gone through there with our research questions, and this is where this grant has been so elemental in saying, okay, well, what are we seeing in terms of changes in health behaviors, in terms of health outcomes, in terms of health knowledge? With our men across the board, we're seeing improvements in these things. With our kids, we're seeing improvement of these things. But it's the auxiliary findings that I think circle back to the medicine wheel philosophies and what Western medicine calls the biopsychosocial spiritual approaches of health, like it's a new thing. And, you know, as we can see here, and we're seeing a lot of our people say, you know what, I was struggling with depression, or that these initiatives that are around diabetes are what has helped me to stop smoking or has gotten me sober. A couple of weeks ago, we had one of the men share with me that he had been involved in leading the youth in a couple of these different activities, and then just a couple of weeks before he'd been introduced, he was suicidal and he had a plan. And so these things are certainly about diabetes, but they're more than that. And I think that as we connect those dots across both of our kids and our men, we're seeing improved health. And under that larger umbrella, diabetes is one of them. But it's a lot more than diabetes. And that's become part of the narrative of all of these programs, is now we're connecting the family, feds, with the men, with the children across the youth activities in school in Ungdayan. How did I do? All right. So I guess open for questions, is that right? All right, shoot.
Good morning. Thank you. I was just wondering, on the infant survey, did you measure drug use?
Yeah, we did have questions on illegal drug use. You
So our local research review board has only approved us to share the slides that we presented. So, but thank you for the question.
For the pregnancy survey, can you give any advice for those of us that are also interested in doing research on Native American pregnancy in terms of recruiting, getting women to participate in the research?
Yeah, we also did the prams for the state in 2014, 2016, and we'll be doing it in 2017 as well. And I think it's very important to meet with as many of the tribal health boards as possible and get buy-in. That's how Sara and I actually started our collaboration, was we went to Sisseton to go over the results of the 2007 tribal prams, the individual tribe results, and also to try to get Sisseton to help us with the 2014 state prams. So I think just having those connections open, and I think I can say this now, like in 2016, we're having more of a problem at the state level with recruitment of American Indian populations. And I think part of that is it is a Department of Health survey. And I think with the whole Standing Rock issue, there's a little bit more hesitation on the part of the American Indian population to work with the state, or else it's just harder to find people. But we have noticed that this last year, especially the last 6 months, has been particularly hard. So if anyone has ideas on how to help, that would be great.
Hello. Thank you. You guys all did good work, and I applaud your efforts. It's one of the bigger concerns I have about the kind of research that I'm interested in, which is a lot of genome research. I'm worried about dissemination and actual public health practice to get kind of intervention type information out there. So I applaud your efforts, and you did a good job. My question isn't directly to you, it's more for the people in the room. I just wonder about certain recommendations like folate or not sleeping with the baby in the bed, and what people feel about that in the room. So for folate, that recommendation has been designed for people of lighter skin color, European Americans, white Americans, whatever you want to call them. And so it's still a question in terms of people with darker skin, if you can overload somebody with darker skin with folate, because folate's destroyed by sunlight. And so when you have it in every single foodstuff that's out there, are you somehow predisposing people of darker skin to other kinds of health effects from overdosing them with folate? And the only papers I've seen so far are from India, where you have a decrease in neural tube defects, but you have an increase of childhood cancers that may be related to overdosing of folate. So I wanted to know if anybody in the room has any thoughts about that. And then the second, for the CP21A genetic variant in Alaska, the variant itself they thought was associated with sudden infant death syndrome, but there was a lot of pushback from the community that said, if done in the right way with indigenous practices, sleeping with your baby or your children actually prevents accidents like that from happening. So I just wanted to know what people thought about in the room.
I can just say, I was an early childhood teacher before I came into this. One of the things that I always did with my kids is that traditionally we would have a swing, a rope swing, and so that's how my kids slept. But it was really close because the rope swing was right above my bed. So in the night when they would cry, I could just hit the swing. And it was really, really nice to be able to do that. But I think having the baby close to you is kind of a cultural practice, and I think is something that you can do. That's all I can offer, is that there's other ways to bring maybe the baby closer to you. And I don't know about any other studies, so other people can have that answer.
I also think the American Academy of Pediatrics, their recommendations are that the baby does sleep in the room with the mother. But it's more an issue of sleeping in the bed and sleeping in the bed in bad situations. And in South Dakota, unsafe sleep practices is a problem with post-neonatal deaths in the first year.
Dina, around him, I just wanted to also respond to that. We're actually involved in a study. I had some questions for you guys, and I'd love to talk more later, but I've been working with Dr. Elliott's Safe Passage study, which looked at SIDS and infant mortality in the region, and we've since developed an intervention study. We're currently going through development of a curriculum related to safe sleep practices, and we've been doing community interviews around cultural perspectives and teachings around the sleep environment. And some of the things that have really come out of that work are thinking about risk reduction and not giving the standard messages that we hear from other outlets and sources that are kind of, don't do this, this is bad, but these are ways that you can protect. And I think some of the data that you guys were sharing from your pilot work is really indicating that women and families are open to reducing risk in certain ways by cutting down on smoking in the environment where the children are, or reducing alcohol use during pregnancy. So if we can encourage ways to reduce risk and talk about it in that language of building strengths, I guess, taking those positive steps rather than saying, don't do this, don't do that. But we're really trying to encourage in our curriculum thinking about the messages that are embedded within traditional teachings around keeping baby close and protecting baby's spirit as a way to protect baby in their sleep environment.
My name is Liz, and I always had my baby sleep in the room, but when I ran into trouble, 2 of my grandchildren were living with me, and the youngest one was a failure to thrive, and it took 2 weeks of going to the doctor to get them to take us seriously, that she kept, she'd be asleep, and then she'd go, and then she'd start breathing again. And we went 5 times before they put her in the hospital. But what we ended up doing was pushing a full-size bed into the corner, and then like making a big crib area around with blankets, where it was about the size of a crib, and then one of us sleeping outside of the blanketed area, where we could have our hand on the baby, and yet we weren't in danger of rolling over on her. But I like the idea of the swing also, because that's another way of keeping them close enough that you can, because I'd always do it when my kids were little. Every time I'd wake up, I'd go feel their chest, make sure they were breathing. But I had a friend that lost a baby with SIDS, and so I was hypervigilant, and my kids always ended up being hypervigilant because I was still doing it when they were old enough to remember it. But that was an idea that we came up with because we were worried about rolling over on her. I mean, she was already failure to thrive, so she was very fragile. And then when we got her put in the hospital, the first nurse that came in jumped all over my daughter and I because we didn't bring her to the doctor sooner because here she was in an oxygen tent, and we're like, how many times do we have to take her to the doctor? And this was not on the reservation. This was in here in Sioux Falls, and it was not we weren't using IHS or Urban Indian Health. But there again, we weren't being taken seriously. I don't know if it was because of being Indian or if it was because she was a first-time mom. I don't know, but there was that was one idea that we came up with. We didn't want the blankets too close to her, but we wanted it so that if we did roll over, we weren't in danger of rolling onto her.
The public health nursing, and I think the South Dakota Department of Health promotes CoSleepers. They're little beds that are right next to the big bed, so mom can sleep right next to the baby, but it's not in the baby, or not in the bed. So CoSleepers are a possibility in addition to the swing and the other bed that you were describing.